And now we segue into Dr. Twaddle. So I don't need a lot of notes to talk to Dr. Twaddle, but I will tell you that one of her folks called me yesterday and was very concerned because she didn't get an email from me or a my chart, because they get my charts from me every single day. I talk to my palliative folks at Northwestern probably 10 to 15 times. I talk to my oncologist because of all the great things they offer. And you know how much I love your folks. I was just there 2 days ago. But when they don't hear from me, they start to worry. And when they do hear from me, they make fun of me. So I figure it's a good thing. But let me introduce Dr. Twaddle. And you guys know I've been raving about palliative care for many years. And it's because I am very lucky to have a group like this. Dr. Twaddle combines nearly 40 years of experience in the care of seriously ill people and their families in a variety of areas of service. She currently serves as the medical director of palliative care for the Northwestern Health System, and previously at the Ward Family Medical Director for Palliative Medicine and Supportive Care for the Northwestern North Region. Her academic work includes developing curriculum, guidelines, and models of care for healthcare professionals to provide care for the seriously ill in all settings. She works with others at Northwestern's Feinberg School of Medicine, exploring how prescriptive nature can improve health outcomes, as well as collaborating nationally in the development and implementation of patient-family-centered quality metrics. On behalf of the American Academy of Hospice and Palliative Medicine, Dr. Twaddle served as co-chair of the National Consensus Project for Quality Palliative Care, which completed the 4th edition of the Clinical Practice Guidelines for the field in late October 2018. Her unique talents and contributions to the field of palliative care have helped increase the understanding of and access to this continuum of care regionally and nationally. In 2013, she was named one of the 30 most influential visionaries in the hospice and palliative medicine by nomination by her peers. She served as president of the AAHPM from 2002 to 2003 and was on the board from 1997 to 2004. She represented the AAHPM in the creation of the initial NCP guidelines published in 2004. She was honored with the inaugural AAHPM Josephina M. Magno Distinguished Hospice Physician Award in 2005. After graduating summa cum laude from Purdue University, Dr. Twaddle received her medical degree from the Indiana University School of Medicine in Indianapolis and completed her residency in internal medicine through Northwestern University McGaw School of Medicine, where she was chief resident. She currently serves as clinical professor of medicine for Northwestern University Feinberg School of Medicine and is board certified in internal medicine, hospice, and palliative care. And with that, my friend, Dr. Twaddle, who, by the way, was at our very first celebration of life in Chicago with my oncologist, Dr. Saras. It's good to see you. I'm still here.
Yeah, I'm so glad.
I'm not sure I'll be here an hour from now.
I hope so.
I mean, but the men's depends will work.
Oh, men's depends. All right. Thank you. It's so good to be among you. I was thinking as Joe was talking, I'm having dinner tonight with my older brother. He just turned 70. When did that happen? And George is celebrating, we're celebrating, not just him being 70, but 15 years survival after stage 4 neuroendocrine cancer. 15 years. Yeah. So you write your own story. And I love that oligo progression. Oligo means little bits. And I think that is so sterling that you brought that up, because a little bit of something doesn't necessarily mean there's a lot of something. And being thoughtful and watching is often the better way to move forward. So I'm going to talk a bit. Thank you for that amazing introduction. And let's see if I can do this. I'm going to talk about palliative care. I am one of the oldie moldies of this field. Had the privilege of being part of the audacious group of physicians at Northwestern in the 1990s during the AIDS epidemic that discovered this way of integrating whole person care into standard medical care, and went to the head of oncology at that time and said, hey, would it be okay if we called ourselves palliative and rehabilitative medicine? He's like, sure. So back then, we didn't have computers and we didn't have to build certain computer programs, et cetera, to do this. So the next day, we took our fountain pens and wrote in our paper chart, palliative and rehabilitative medicine, and went on to develop a specialty in the field, wrote the first board exam. I mean, talk about audacious. It's just amazing to think about. It is now the 5th largest subspecialty of medicine in the United States. And when I go to meetings and I see 2,000 people and lots of young people, my heart is so full. Because this area of medicine is so critical for every one of us in really restoring medicine to what it was intended to be, quite honestly. We created a subspecialty to rejuvenate and refresh and bolster the wholeness of medicine. And I'll explain a little bit about that. So palliative medicine is a team sport. We use the term interdisciplinary. The best analogy is the hand, meaning that we really need a team to better assess and support people and their families who are dealing with serious illness. It's beneficial, and there's so much evidence that this makes a difference, and I'll share one of the studies that really got the attention of our oncology buddies years ago. The difference between palliative medicine and I think kind of traditional healthcare as well is we anticipate what might happen with an illness and get there to set up a plan rather than helping. What I say to my patients on a regular basis is, I don't want you to earn relief through suffering first. And our entire healthcare system is based on that. They wait for you to get sick, and then they start helping you. Why is it that we don't anticipate what the potholes might be and just walk around them? Or pave them over so that we don't have to suffer, because that suffering doesn't help us earn badges or be better off for having gone through it. So palliative care is delivered by a team in all sorts of different settings, integrated into standard health care, and it has been shown to improve quality of life, to ease symptom distress, to support caregivers and lessen caregiver stress, and to improve prognosis. People who with the early integration of palliative care actually live longer than those who do not access this type of support. And that was one of the major game changers to discover that. So again, team-based, anytime. It is integrated. So one of the analogies I hear a lot, and I actually don't like it very much, is it's an extra layer of support. To me, that sounds like icing on top. I do like icing, but on top of the cupcake. Whereas palliative care is actually, one of my doctor friends says, you melt into the system and help us function as a team. Because one of the things that happens as we get older is we start to collect different doctors, different healthcare people, and especially when we're in the hospital, it's almost comical, if it wasn't so serious, that we're dissolved into all our organ systems and we have a different person assigned to every one of them. So who reintegrates that and sees us, sees our mom, sees her dad, sees all of us as people first versus illness? I love what you said about, I want to know who you are, not what's your diagnosis. And that's probably the biggest difference when, and Jill can attest to this, when you meet a palliative care person, they want to understand who you are, what brings you joy, how do you cope with stress, how much information is helpful, who do you need with you when you get serious information, do you like to hear it alone, do you want somebody there, all these different aspects before we even get to the place where we're starting to talk about the illness and what we're going to do about it. Because in light of who you are and how you live in the world, that's what we want to support as you're dealing with a serious illness. So we call it palliative medicine and supportive care, reflecting that it is a subspecialty of medicine. And the supportive care will integrate into any other health team. So cardiology supportive care, pulmonary supportive care, cancer supportive care. We're going to integrate into that team and help them to function. And again, what we help with is symptom burden, good old quality of life, how you define quality of life, caregiver stress, which is huge. Having been when my brother was diagnosed, it was fascinating to me. I'm the baby in our family, and he came and stayed with me during his post-op period, and I assimilated a lot of his symptoms. It was fascinating, but not. I lost 10 pounds, I had abdominal pain. He'd call me at work, I go, "What's wrong?" He's like, "I'm at Home Depot, do you need anything?" But being a caregiver is extremely stressful. And so when we wrote those last guidelines and published them, one of the things that we asserted within the guidelines is it's important to assess a person and their illness and their stress and coping, but then also assess their caregivers. Are they confident? Are they stressed? Do they need more support? And figure out a way to help them. And we put that in the guidelines, that it was essential, and guidelines help support policy and payment. And so some of the insurance companies started to support caregivers, which is, thank goodness, because we need that. We need sometimes just practical, hands-on help when we're trying to take care of somebody that we love. So I keep using the term serious illness. A serious illness is defined as an illness that has an increased risk of mortality, so it's a big deal. And it's associated with some changes in terms of our function, quality of life, or caregiver stress. So typically a person who comes to us for palliative care has a serious diagnosis, and they're oftentimes starting to see that illness affect them physically. But not everybody. So we see patients, for example, who have head and neck cancer, who may have no symptoms whatsoever. It was found incidentally, but they're going to go through chemo and radiation, and that treatment is super rough. So we want to be there, again, ahead of them developing complications or side effects or losing 50 pounds, and get them through. So palliative care support, anticipating, supporting, assisting, and for anyone, even if the outcome is that you're going to be cured of this, even if you have something that can be surgically removed, but to get to that place is going to be rough. Most of us cure. What is cure? We're going to live with something. It's going to change our lives. So how do we live as long as possible, as well as possible, in ways that are meaningful and effective for us and for those that we love? So we engage ourselves with those, particularly with cancer patients. We work within the cancer center. We're embedded, as we say, in oncology, and that model has been shown to have tremendous positive effects. We're also integrated into heart failure, pulmonary disease, neurologic conditions. I see a lot of patients with Parkinson's disease as well. And those too, caregiver issues, how do we navigate this? And I think the tougher thing with some of the neurologic is the person isn't even aware of their impairments. And their caregiver really is the center of who we're trying to support in the unit of care, because it's so hard to watch them change. So we touched on the word hospice, and hospice is where the idea of palliative care arose. There was a gentleman, Dr. Balfour-Mount, who just died I think in the last month it's been. I lose track of time, but Bal was one of my mentors and teachers in my career. He was in his 90s, survived 3 different cancers. He was a urologic surgeon at McGill University, and he did his oncology fellowship at Memorial Sloan Kettering, and then he likes to say, I went across the pond, and I studied with Cicely Saunders, who was the person who developed the modern hospice concept. And then he came back to Montreal with this desire to integrate this whole person care into oncology and into urologic diseases. And hospice in French-speaking Quebec means a halfway house, so the name was out. But it wasn't about end of life. It was about serious illness and people who had potentially months, years, decades to live, but needed really assertive companionship and support throughout that whole trajectory. So he's the one who coined the term palliative care. and palliative medicine being the discipline. So hospice is a form of palliative care for people who are at the end of their lives. And when care is really all about treating symptoms and we can't do much to modify the disease, so typically folks who enter hospice are stopping disease-directed treatments. They're not being forced to stop them. It's that the disease-directed treatments are taking more from them than providing to them. So we make those decisions. It's oftentimes a process, and the care is focused on really squeezing everything we can out of life in the time that we have. What's also interesting is the early integration into hospice care when it is appropriate for us. Those people also live longer than those who don't use hospice care, which is kind of an oxymoron. It's particularly true with non-malignant illnesses, but it's also true with cancer patients. And if you think about it, when you have a nurse who's coming a couple times a week, as often as is needed, but you also know that if something should happen on Saturday afternoon or Sunday night in the middle of the night, that there's somebody who's going to respond to you and help you, the stress hormones decrease. And you've got this whole posse of people. Now, I will say that if you've seen one hospice, you've seen one hospice. Even though it's a government, certified service, you need, just like Joel was saying, you need to be a really discerning customer and ask lots of questions, because there are some awful things that have played out in hospice care. Whether they're a for-profit agency or a nonprofit, it's about the quality. It's about the model. It's about the people. And you want to interview probably more than one. And I encourage my patients to often interview people for hospice way in advance. One of my gals, just recently, we thought we were at that point. She interviewed hospice, and then things changed, and we're not going to use it. But she knows which agency she's going to use when she needs to, and she's in their system. So that if something happened, if the bottom fell out of life and she wanted to do a pivot, they're going to respond. So that safety net in and of itself has really helped her. So all that is hospice is palliative care, team-based care, quality of life driven, symptom management, whole person, but not all that is palliative care is hospice. And I oftentimes have the joy of caring for my patients for years, if not decades. So very different than hospice care. And in our team, we like to stay with our people. So when they do elect hospice, we stay with them. We remain their care team as part and integrate into the hospice. So we're, again, discerning as to which hospice we recommend. There's a handful that we like to work with. And you can always graduate from hospice because sometimes people do get better. I had one gal who, stage 4 breast cancer, who got substantially better in hospice, graduated, went into physical therapy, lived another year, and then the disease reared up again. But you never know, because you're going to write your own story. And we use these supports in ways that help you do that well. Palliative care the idea is kind of dosing to need, integrating and being there. There may be periods of time where you don't really need your palliative care team. We love the fact that there's this wonderful relationship because it's therapeutic for us as well, that you worry about your people when you don't hear from them. You want to know you want to celebrate with them, and you want to be there for them. So it really is a relationship-based medicine that is longitudinal and integrated. Lots of C words, comprehensive assessment, communication, coordination, collaboration, all these wonderful words. And I like to use the analogy of modern medicine's kind of like, I was a swimmer. I was a long-distance swimmer when I was growing up. That's kind of medicine. We're in our lanes, we're doing our flip turns, we've got our lane markers, we communicate in the chart, But everybody's in their role, right? And I'm dating myself, but palliative care is like Esther Williams, okay? We've got no lane markers. The person in their family, whether they be biologic or chosen, whoever they deem family, is in the middle, and all these people in funky bathing caps are around them, trying to coordinate, collaborate, communicate, buoy them up. That's the idea. It's really a dynamic. And communication is critical. And I really think that one of the things our team helps with tremendously is that the rest of the team communicating. Because how often we have to tell our story over and over, every doctor we go see. Don't you talk to each other? Well, we really work hard to make sure that the team actually huddles and talks to each other and communicates and knows, so that people feel like we're all rowing in the boat in the same direction and working on their behalf. So this study that was published in 2010, and I'm really proud because of the women who did it, who led it, are two of my friends. You go, girl. They're both at Mass General. And they did a study looking at stage 3 and stage 4 lung cancer. And it was published in the New England Journal of Medicine, which is a big deal in and of itself. It was a 3-year study. The patients were randomized to either receive conventional oncology care at Mass General, really good place, right, Harvard, or to see their oncologist and palliative care just in the clinic. It was just in the clinic. They, kind of like what we do at Northwestern, is they would see their oncologist plus minus their palliative care, might see their palliative care separate from their oncologist, but they were receiving it in that setting. So they followed these people for 3 years, and what they found is they had much better quality of life, improved mood, depression was anticipated or treated, managed when it showed up, much more decisions around goals of care, what do I want, what do I not want, documentation of that. Most people in this study, when the end of life showed up, had anticipated this and had planned for this, hoped for the best and planned for the rest, and chose to really map it out in ways that were meaningful for them, so it wasn't crisis intervention. But the big thing that caught the eye of the oncologist, that absolutely dropped their jaws, with the group that received palliative care lived on average 3 months longer than those who didn't. Getting the same oncology care, 3 months longer, which is on average. I mean, some significantly longer. And that's pretty much what a phase 4, treatment or another cycle of something else is going to give us, is months, not years or decades. So this was riveting. I still remember I was in my office and there's a knock on the door, and I opened the door, and one of the oncologists says, did you see that study? I'm like, yeah. He says, I think I need you. So it was a huge catalyst for the greater integration of palliative care into oncology care, and it is now, to be a certified cancer center, to be considered of the highest quality, you have to have palliative care integrated into your service line. There are certain quality standards that we have to reach. That in our meetings, when we talk about our cancer care and all our plans, palliative care is there to help strategize and plan alongside all the other aspects of oncology. So a new world has been born from that small group of audacious docs at Northwestern. It truly is a game changer for people, and the early access of this type of care can make a huge difference for you and for those who love you, is really important. Our motto at Northwestern is to live well and land softly. So that's it, and I'm happy to take any questions. Don't be shy.
So, I was a healthcare worker for 45 years, all right? I'm the supporter.
Yeah.
She's the fighter. But what I notice is that a lot of there isn't a lot of talk about medical marijuana. You know, and especially when we're talking nausea, people are having problems, you know, with appetite and things like that. What's your take on that?
So medical cannabis. So the challenge is, even though it's legal in Illinois, it's still federally illegal. And when it's federally illegal, well, the world's a mess right now anyway, but there's no funding for research. So there is very little research, randomized trials, dose finding, identification of what is the substance within the THC that does the good work for whatever symptom.
Right.
It's all seat of the pants. And so I am very blessed, and I think it's called Prolio. One of our ICU nurses really made a commitment to learning everything she could about medical marijuana. And so she's a resource. We don't prescribe medical marijuana because there is no prescription. We don't know what to tell you to buy. We do know it's super potent compared to what it used to be. But I turn to somebody like Rebecca Abraham and I say, hey, will you talk to my patient about what their symptoms are? And they'll figure out what strain. Is it a gummy? You know, what are we trying to cover here? Because since we don't know a lot about the substance, we can't anticipate how each individual is going to react. Some people can get tremendous dysphoria with marijuana. I had one of my gals go to a dispensary, take it, go in the grocery store, and just puke through every aisle. It was the most mortifying experience for her, you know, but it was just horrible. But it's because the people who work there don't know. They may have very minimal idea of how even the strain that they're giving the person is going to be acting. So I rely a lot on my patients and what they've taught me. It does have some efficacy with nausea and appetite. It can help with sleep. But again, some people can have a pretty awful experience with it. And it's also very expensive. So, and you gotta be sure it's pure. So I really look at what's the community out there that could help guide my people to find what they need with medical cannabis. And then we just gotta get it legalized so that we can start doing controlled trials. One of my friends, David Cassaretti, is at Duke now. He wrote a book called Stoned. And David did research on cannabis, read widely. There's stuff in the veterinary literature, interestingly. And what he found is there were some real decent outcomes using cannabis. But again, what part of it, right? And what ratio? And certainly the CBD, not a problem. It's an anti-inflammatory.
Right, doing a mixture
Yeah.
of them now.
But how much
Sure.
is the mixture? And that's what we don't know. We don't know. Yeah.
I have to agree that I'm the caregiver and I have a lot of similar symptoms to the patient.
Yeah.
And I thought I was making that up, so.
No, we
That-
assimilate them. Isn't
It's
it amazing?
so bizarre.
Yeah.
My question is, we were at Northwestern, we did visit palliative care a couple times, and then we switched hospital systems because our doctor left. You work for Northwestern, is it wise to just go back to who we started with? Or do we go to the new system, which is not Northwestern, where he has oncology, and see if they have palliative? I mean, we haven't looked into it.
Can you share what other system you're in?
City of Hope, which is the satellite office is downtown.
Yeah, and I don't think they have a strong palliative care program yet.
Okay.
I'm hoping that they will, because their parent organization out in California certainly does, has, knock it out of the park palliative care. So it's worth asking and meeting their people and finding out how they work because it's convenient. But you are not limited.
That's
So
what I'm wondering. So
yes.
Since they have
No.
some history,
Yes, I see many of patients who are not part of Northwestern.
got it.
It makes it tougher because, again, it's a team sport.
Yes, that's what I was thinking.
There's some health systems in particular, really the other two big ones in the area, where we're not on the same medical record with one, and that makes it a pain in the patootie, and the other, I just can't get to their doctors. I can't get to them.
Yeah, I
You know,
think
it's
they're on
like-
the same
so,
system.
yeah.
They're on the same filing
Yeah.
system, and we can link those together.
Yes.
So, okay, thank you very much.
Yeah. It's thrilling in today's world with electronic medical records because I can, my patients go to MD Anderson or they go to Sloan Kettering I can see the notes. I can collaborate, and that is so amazing to me. It feels like the world just shrunk by major, major measurements. Oh, there I go. I'm going to turn into a pumpkin. Any other questions before I twaddle away? I will tell you really briefly. Twaddle is my maiden name, and I kept it because it literally means silly nonsense. And my dad said to me, Martha, when you practice, keep your name because it will really keep you from taking yourself too seriously.